right, everybody. Hello, my name is Clark Madsen. I'm past president of the Ogden Surgical Medical Society, and I will be moderating this final session for today. We are fortunate enough to have some excellent speakers coming up next. We're going to be doing our McCady Family Medicine resident talks. These are going to be 7 talks, short sections of different projects that are going on in our community that are supported and worked on by graduating residents in our community. First, I want to show appreciation for all of you who've been involved with the residency in our community, who've helped teach or been a part of the residency itself. So very much want to thank you all for that. I'm going to ask that our speakers, looks like they're already doing it, I'm going to have them come sit up here close to the front. And the way this is going to work is these senior residents are getting close to graduation. They've been working on these projects sometimes 2 to 3 years, and they're going to be kind of explaining what they've gone through, presenting kind of their scientific findings. And then what we'll do is we're going to split it up into 2 sections to keep it moving quickly. They'll talk for about 10 to 12 minutes, and we'll have the first 4 talk. Then I'll have them come up here. They'll be able to answer questions from the audience. Then we'll do the 3 remaining residents, and then they'll be up here to answer questions from the audience. And so for the first session, I wrote down our speakers here. We're going to get going here pretty quickly. And first we're going to hear from Dr. Yokas, then Dr. Reynolds, and Dr. Ray, and Dr. Olavison. And at that point, we'll open it up for questions. Thank you.
Hello. My name is Mackenzie Yokas, and today I'm going to be talking about my project to increase access to gender-affirming care in our residency clinic, Porter Clinic. I will be going to Intermountain South Ogden Clinic when I graduate. I'll be really excited to stay in the area, and I have no disclosures. One thing I would like to drive home during my talk today is that gender-affirming care can be provided by primary care, and that is the main goal with my project over the last few years. I was fortunate enough in medical school to be able to see family medicine's attendings and residents prescribing gender-affirming hormone therapy in clinics, and I learned a lot from them. When I came to McCady, there was an amazing endocrinologist at McCady Hospital who was prescribing gender-affirming hormones to the majority of our resident clinic patients in Porter Clinic. Unfortunately, during my intern year, Dr. Ganiato left, and that left a pretty big care gap in Porter Clinic. And there were patients who were left without their hormone therapy, and there were patients who were coming into clinic hoping for referrals for close hormone therapy who weren't able to get it. I took my lessons that I had learned from the University of Utah, and I reached out to one of my faculty mentors, Dr. Taylor Stoddard, who very enthusiastically decided to help me get resident teaching and everything that we would need to be able to teach residents to prescribe gender-affirming hormone therapy within Porter Clinic. The reason why I became so passionate about this, and the reason why I really pushed to get the resident clinic to prescribe this therapy, was because of the numbers in the following slides. So this first image is an AI-depicted image that I made from a study published in JAMA in 2023 that showed that the suicidality rate for transgender and non-binary individuals was 498 to 100,000 person years compared to 71 per 100,000 in the general population. An additional study indicated that transgender and non-binary youths who receive gender-affirming care, such as puberty blockers and gender-affirming hormones, had 73% lower odds of suicidality. Gender-affirming care is life-saving care, and I really wanted to have our resident clinic pushing to prescribe this. When I talk about gender-affirming care in this talk, I will be mostly talking about gender-affirming hormone therapy, but one thing I would like to caveat is that it really is a lot more than that. It can be something just as simple as using correct pronouns and joint decision-making on healthcare goals, along with gender-affirming hormone therapy and surgeries. When I started this project, Dr. Studden and I met with Dr. Sullivan at the University of Utah to help find safe ways to incorporate this into our clinic. And my project started about the fall of 2023, where I gave a noon conference lecture on some of the basics of prescribing hormones in this setting. This was basically just a summary of the already existing Intermountain care process models. I wanted the residents to be able to know where to find this information, and I wanted to give a quick overview. I also provided our support staff with education modules from Fenway Institute to help with this process. I then took a step back, and I wanted to see, based off of just giving those lectures, how many patients would start receiving or being prescribed gender-affirming hormone therapy in our clinic. My goal last year, by the end of April of 2024, was to have 5 patients in our clinic actually prescribed hormones. And I met that goal by pretty early on, like at December of 2023. And by the time I presented here at Ogden Surgical on this project last year, we had 7 total patients prescribed. I am pleased to say that we have now increased to 10 total patients, and we have had 3 providers who have been prescribing these hormones in that setting. From here, I wanted to continue to improve the quality and make sure that we were giving great, safe care to our patients in our clinic. And another resident, Dr. Baumgartner, whose poster you'll see just out here, and I decided to send a survey out to our existing gender-affirming patients. Out of everybody we sent the survey to, 7 responded. And one big thing that I noticed in that survey was no respondents had an experience that made them feel uncomfortable in our clinic. That was a huge win for me. And we also had them rate their satisfaction in our clinic, and the average answer was 93.4%. Again, a really big win for our clinic. We also asked them to identify barriers to their therapy. The most common answer was navigating therapy and surgery resources. Other common answers were cost, provider knowledge, lab monitoring, and medication refills. Dr. Baumgartner took on the navigating resources as her quality improvement project, and you'll see that on her poster. She provided patients with information packets on some of this. But I took this and brainstormed some of what I had originally thought to be barriers to prescribing quality gender-affirming care in our clinic. And one thing I had identified last year even was the provider knowledge aspect. And given the fact that the patients had also identified provider knowledge as a barrier to care, I decided to continue to tackle this. One marker I noticed when we started this project was the fact that only 3 of us residents were prescribing gender-affirming hormones after the initial lectures. And I was curious to see that if further education and ease of resources would increase those numbers. So for my next part of the project, starting this last fall, I aim to increase the number of gender-affirming hormone therapy prescribing providers or residents in our clinic to 7 by April of 2025. In doing so, I repeated the exact same lecture I had given the year before, but I also simplified it into checklist format for both the residents and patients. As you'll see, these are the checklists that I provided, and okay, there we go. For the provider side of things, I focused on how to conduct the first several visits, because the first several visits were probably the most complicated for this. that included making sure to give the resource packet that Dr. Baumgartner made, to make sure that the providers were reviewing the questionnaires. I highlighted how to find the order sets, which included all of the labs and the intervals of the labs that were needed, along with the different hormone formulations that are available and can be discussed with patients. I also include making sure that the residents signed the consent form with the patients, and these are pretty extensive consent forms. They're about 6 pages long. But on the patient side, I had them include all of the things that somebody would want to put in the history section of their initial intake exam for gender-affirming care. Things like whether they're desiring feminizing or masculinizing therapy, their physical goals or their general goals and characteristics, their support, and also some pertinent past medical history that may increase risk of certain therapies, including blood clots, cancers, heart attack, stroke, all of that. I also wanted to give the patients some autonomy in this as well, and some empowerment over their own care by giving them a section where they could say that the provider gave them a resource packet, the provider got their labs, they discussed all of these with them. So that was my main intervention. From there, I started measuring how many providers started prescribing. So like I said, I see how that's easy to do now. After the first intervention, that first lecture, and the modules provided to intake staff, we had 3 providers prescribing gender-affirming hormone therapy. After repeating a lecture exactly a year later, that number jumped up to 5 total providers. And then after distribution of the checklist from the slide before, we got to 6. Unfortunately, we did not hit my goal of 7, but there are now 6 new residents who are building their confidence to be able to prescribe gender-affirming hormone therapy when they graduate, and that is still a win to me. We are obviously very early on in this project. We have very few patients right now, and my goal is to continue to hone the quality of care we are providing in our clinic before we really target high patient numbers. I think some things that we could do going forward would be surveying the residents to see what their barriers to prescribing are, and continuing to survey the patients and trying to provide them with the resources that they need. Our goal is to also ensure that we provide care in compliance with the current laws in Utah as well too, so we'll be keeping a close eye on those. These are the references for the studies I used before, and I would like to say I used AI to make all of my images. And then I would like to thank Drs. Madsen, Stoddard, and Baumgartner for their help with this project. In the spirit of hoping to empower other primary care providers to learn more about this, I've included some QR codes for the UCSF guidelines. These are standards of prescribing hormone therapy that most physicians doing this use in the US. And then the Fenway Education QR code is for the modules that I use to help with the support staff, but also there are a lot of really great modules on there for providers as well. I also included a picture, a part of the Intermountain Care Process model. If anybody is interested in seeing that, I have those with me, and you guys can touch base with me later. Thank you.
All right. Good afternoon. I think we'll figure out how to use this. Awesome. I am Chase Reynolds. I'm one of the third-year residents at McKay. I'm an Ogden boy, born and raised. Happy to be back at my alma mater presenting. Following graduation, I'm excited to be joining the Layton Family Medicine group. It'll be a mix of inpatient and outpatient work, teaching the residents, and hoping to stay involved in the community. I have no disclosures. For my QI project that I worked on over the last couple of years, we worked on improving residents' comfort with repairing vaginal lacerations associated with childbirth. some of the background on that is that family medicine residents are required to perform a minimum of 20 vaginal deliveries during their residency training here at McKay. Many of our residents perform far more than that number, but that's kind of the baseline. According to ACOG, somewhere between 53 and 79% of vaginal deliveries will include some type of laceration, with a subset of those cases requiring some form of laceration repair. When these lacerations do occur at McKay Hospital, where we deliver our babies, residents are encouraged to perform those repairs, of course, where feasible. Cases where there's an advanced third-degree laceration or certainly fourth-degree lacerations, those are typically handled by the surgeons. From kind of an early point in my second year of training, it was kind of pointed out by a number of our OB providers that some of the residents sort of appear uncomfortable when that happens. So residents appear to do fairly well with delivering the baby, and then when it comes time to not only identify a laceration, but then certainly moving into a repair portion of that patient care, patient or residents were reporting, that they felt unsteady, unsure of how to proceed with that, and were requiring a pretty extensive amount of attending input to complete that repair and do so in a satisfactory way. And then beyond, just the comfort standpoint, there's a degree of competence that also was evidently lacking at that point. Looking at a process map of the process of delivering a baby, identifying a laceration, repairing, and then following up with a patient, we were looking at ways that we as residents could improve our technique and our comfort level in performing these repairs. And so once a laceration has been identified, then, and we've gone through all the steps of understanding what supplies we need and those sorts of things, which are the basis of our initial training, the focus then turned to the actual repair and how we improve on that. For some further baseline data that I collected for this project, I sent out a poll to all the residents, first, second, and third years. We have 21 residents in our program at any given time. And the residents were asked to self-report their level of comfort when they repair these vaginal lacerations. And the scale goes anywhere from feeling completely uncomfortable with repairing the laceration, regardless of who's present to help them, up to a resident who feels completely comfortable repairing a vaginal laceration without any supervision. The initial data did surprise me a little bit, but based on the conversation I had with our OB providers, maybe met a little bit more of what they were seeing on the ground. We had initially 17 residents who responded to this first survey. As you can see, 7 of our residents at that time felt totally uncomfortable, with 9 stating that they felt okay performing a repair as long as they had constant supervision and input of what next steps, where to place the suture, etc. And only 1 resident who said, I feel like I could do okay as long as I just have a little bit of input here and there, with none of our residents at that point stating that they felt comfortable performing the repair independently. This was a little disconcerting because we do have residents who go out every year that are performing primary obstetrics in different parts of the state and region, and so we wanted to improve on this. My mission and aim, the mission, of course, is patient-centric, and the goal is to improve maternal outcomes following childbirth-associated vaginal lacerations, with an aim to increase the number of residents who had reported comfort repairing vaginal laceration with minimal attending input from 1 to 5 at the time of our initial end, which was May of last year, or March of last year, excuse me. For an intervention, the residents were again kind of pulled in a follow-up to the initial questionnaire, asking how they felt they could best improve their skills and thereby their comfort level in repairing these lacerations. And it was identified that an OB/GYN-led suturing lab would be the intervention most likely to improve their skills and their comfort in performing the repair. What we did with the first year in January, we had a structured skills lab with Dr. Chris Murphy, who's one of our laborists over at the hospital. And we used a teaching PowerPoint and some information from a QI project that was actually conducted at the University of Washington OB/GYN residency, where they used a cow tongue model to replicate the vaginal tissue that we would then be learning how to repair. So we did this initial intervention at that time in January, and all of the residents were given a repair practice kit that they could then take home with them. Part of that was because we didn't have sufficient supplies on hand for all of them to do these repairs, but also so they would have material that they could take with them. After this initial intervention, I again polled the residents at the end of that study period in March, and you can see that initially we had, as I mentioned, 7 of our residents who had reported they were totally uncomfortable, and that number dropped down to 1. And this was with the same cohort of residents. We had not received any new or had a turnover of our residents at that point. With the number of residents reporting constant input needed from 9 decreased down to 8, but the biggest jump that we saw was a jump from 1 resident reporting comfort with minimal supervision up to 6, and then we had 1 resident who stated that they felt they could do this completely independently. This was really good news because last year we had 1 resident who graduated to go on and do primary obstetrics, and so Dr. Christensen, kudos to him, he was the one who felt he could do this. After this initial period, we felt that this was something that could be rolled into subsequent years to continue to train the residents in a way that they felt on a rolling basis we were giving adequate education and practice opportunity to get really good at repairing these lacerations. So at the time of the new residency year in July, as part of the orientation for incoming interns, we provided this same laceration repair lab with Dr. Murphy. All residents were invited to that, and then we again repeated it in January. So we had an additional 2 training periods with all of the residents. And at the end of now this year, we've had further input. I would note that we had more residents who responded this year. We had 20 of our 21 residents who responded, but we've again had an increase in the total number of residents who have kind of moved from this constant input category over to where we now have 7 residents stating that they feel comfortable with only minimal input, which I should also state that in all cases where residents are performing vaginal laceration repair, an attending physician is present for that. And so that's a satisfactory degree of comfort, where we now have 3 residents who are stating that they feel comfortable with repair independently. I would also note that of the 10 residents who reported this year that they would require constant input, 6 of those were our intern residents, and then we had 2 of our third years who are not planning to do any degree of childbirth or vaginal laceration repairs from that degree, and then the other 2 were second year residents. But again, we had that shift toward residents feeling more comfortable repairing these lacerations. Going forward, the plan is to continue with these twice yearly suture labs again in July and January, so that residents can continue to improve their competence and also their confidence. I believe that going forward, it may be worth, maybe for somebody doing a follow-up QI project, doing some form of formal evaluator feedback to the residents immediately following childbirth and laceration repair, so that they can learn in real time or be evaluated in real time. And then Dr. Alexa Fritsch, who's one of our second year residents, is currently working on a project that kind of parallels my project. She's reported on that. She's got her project on a poster outside, but also working at improving resident comfort and skill by using desktop models, essentially, that are strategically placed in the hospital for residents to practice. Additionally, I think another area where we could follow up would be looking at patient satisfaction. Given the mission statement to try and improve maternal outcomes, including comfort and cosmetic appearance and so on, we could then also apply some form of questionnaire at a 6-week postpartum follow-up where they come into the clinic, and we can parse out how they're doing. My information came from ACOG, and then this laceration repair program that was implemented at the University of Washington. I just want to thank Dr. Murphy, Dr. Lammy, Dr. Madsen, and Dr. Campbell who helped with this program. Thank you very much.
Alrighty, my name is Dallin Ray, and I will be discussing PRP, or platelet-rich plasma. And I did a literature review, kind of a deep dive into some of the studies regarding PRP. This is a picture of my family, and we just added another one. We haven't got a new updated family picture, so I just threw the new one up there. After post-graduation, I accepted a job at Kaja Family Practice, which we are super excited for, up in Burley, Idaho. So I threw a farm field to feel more at home. I don't have any financial disclosures yet, so reach out to me. PRP, why is it interesting? So in the summer of 2023, there was an article posted in the Journal of Family Practice, which it said, which patients will benefit from PRP? And it listed out very plainly which ones would, which ones we're not sure. And so it made me start looking into PRP and some of the nuances. And it's a pretty highly debated topic of how well it works. You have some people that totally swear by it and say it's the best thing ever and fixes everything. And then others that say it's not worth the money, it's not worth the time. So just to give an overview of what PRP is. So it starts as just a normal venous blood draw of the patient's actual just normal blood. It's put in a centrifuge. It's spun down for a certain amount of force for a certain amount of time, depending on the protocol. So you'll get the separation of the blood products. This little section right here, the purple, it's not actually purple, but in this picture, it's a platelet-rich plasma that's drawn out, and it can either be spun again for a different protocol, or it's just then injected into what we're trying to fix. So what can PRP do? A lot of different things is what it's used for. So wound care, hair restoration, skin rejuvenation, dental. What I focused on was the tendinopathy, OA, ligament injuries, muscle injuries. All the studies I was looking at were looking at these conditions. But the other ones are also available. So contraindications, very, very few. So obviously if you have some sort of blood malignancy, you're not wanting to be injecting that in different parts of your body. If you have allergies to they come in as a kit that you'll get, and so if you are allergic to any parts of the kit that the blood will be suspended in, you don't want to inject that into places in your body to have a reaction. Or if you have an active fever, there's an infection going on, just wait, get it done later. Questions that I wanted to answer is, one, should we offer PRP injections for patients? Is it valid? And then second, why is there such variance in reported outcomes? Why do some people absolutely love it? Why do some people not like it? And why are we arguing over that? So I had to kind of cherry pick studies that would make the most sense for everyone. And so first one, British Journal of Sports Medicine. This is the actual title. It says, strong evidence against PRP injections for chronic lateral epicondylar tendinopathy. So if you were to read that article back in 2014, strong evidence is strong words. So now going on to the second one, this is the Association of Bone and Joint Surgeons, as PRP, or autologous. This is just meaning you drop someone's blood and inject it straight into a site. Do not reduce pain or improve function in patients with lateral epicondylitis. And I'm focusing on the lateral epicondyle just to keep the theme going. But so you got two against. I don't know if you guys would read those two and be like, yep, I'm doing it. But maybe you had some questions. Moving on, a NIH study in 2017. This was a meta-analysis and review. They came up with kind of cherry-picked out of their conclusion. It says PRP may provide some benefits in patients with knee OA and lateral epicondylitis. So a little more favorable. We're getting there. Maybe it's working. And then later on, there's this sports medicine position statement that was sent out in 2021, and it said multiple randomized controlled trials have demonstrated that lateral epicondylopathy responds positively to PRP injections. So that seems like, okay, maybe that is a good thing. So what should we be offering it for our patients? Depends on which studies you are reading. And then why is there so much variance? Why in just a couple years, one of those studies actually included, like the lit review actually included the exact same studies as one of the earlier ones. So why is there a difference in reported outcomes? And a lot of it comes down to how PRP is prepped. So if you look, there's a difference in how much blood you draw from the patient directly. So anywhere from this study just did 3.5 milliliters. And then this one, basically a unit of blood was drawn from the patient. It's then spun with a certain amount of force. This one was 100 of their units. This is a unit of 300 times more for a certain amount of time. So a couple minutes versus all the way up to 10 minutes, 15. And some of those you then pull off the platelet-rich plasma, that section, that buffer coat, and then spin it again to get it even more concentrated. And that makes a huge range of concentrations of platelet-rich plasma that you're going to be injecting. Why that's important is in the platelets, there's growth factor. There's, VEGF is probably one of the most known. People hear that all the time. But there's a lot of cytokines. There's other growth factors in there that in vivo studies have shown to promote healing. And so that's what we're focusing on. So we can have as much as 2.6 times, which a normal person has 150,000 to 450,000 platelets. So that's still under 1 million, versus up here, when you start with a ton, 83 billion, which it's hard to compare apples to apples when you have that much variance. And that's not even going into whether the platelet-rich plasma is leukocyte-rich versus leukocyte-poor, whether you activate the platelets with like a calcium chloride to put it in, make it more readily available, or if you inject it and let it break down and become available a little bit later. And so when people are designing these studies, they have to decide what they're going to include. So the first study, that number one that I mentioned, 3 of the studies had one had 2 times the platelet concentration, one had 2.8, one had 5.5, one had just reported that the average was 8 times the concentration, but we don't really know exactly. And then a couple of studies didn't even report the platelet concentration. So we know they were injecting PRP, but we don't know. 3 of those studies actually suspended the platelets in bupivacaine, which now is more readily known that it actually inhibits the function of some of those growth factors and cytokines, but there was still benefit in everything that was seen, just not statistically better than some of the controls. Now, and their conclusion was strong evidence against PRP. So go to study number 3 that I mentioned. They were a little bit more picky on which studies they included in their analysis. So they didn't include any PRP in concentrations less than 2 times, so they're stuck with the 3 to 10 times. None of the studies suspended the solution in bupivacaine or were injected with bupivacaine. And then their conclusion was PRP may provide some benefits in patients with knee OA and lateral epicondylitis. So why variance? So now we get to the question, would I recommend PRP? Why all the variance? And it comes down to, it is hard to design a study because everyone has different protocols for PRP. Anytime they did a lit review, they had to decide what was included. And so as time goes on, we kind of decide what protocols are working. More people are using those protocols, and it's becoming a little more efficacious. So would I recommend PRP? Like everything in medicine, it depends. A lot of it comes down to what are the alternatives. So if a patient hasn't done anything, there's sometimes cheaper alternatives. PRP is usually a cash pay option. And so there's a lot of money to be made to have patients just come in and have a cash procedure. But if they haven't done some of the more routine injections, such as steroid injections are up there in some of the most routine. Physical therapy, there's also prolotherapy where you're injecting other irritants like dextrose in there to promote healing. PRP might be more expensive, but there's maybe not that big of a benefit for a lot of different conditions. If the alternative is surgery, I think there's the cost there and the risks are very low. And I think PRP fits in that niche of patients have tried a lot of different things. They're still having pain. They're still having poor outcomes. And PRP is another tool in our toolbox that we can use, we can recommend to patients to help get them feeling better. And in the future, I feel that standardization, proven protocols will make it easier for the general clinician. You're not trying to decide what concentration for this random spot in the body that hurts. There's this one tendon. I don't know how much platelet-rich plasma to inject. If there's a solid one that you can just go with, it's easier for everyone to stick with. I have a bunch of resources. If you are having a hard time falling asleep, you can read a lot of these articles. But thank you so much.
Hello, y'all. I'm Alex Lavison. Very happy with my choice of slides as I get to copy the fantastic Dr. Ray. Today, I'm doing a literature review on clomiphene citrate as an alternative option for secondary hypogonadism in a reproductive age males. Unfortunately, I did not include a picture of my future plans, but I do have a quick update. I learned today that to become a master of testosterone, somebody has to be married and have 3 daughters. Fortunately, I fit those demographics, so hopefully I have some clout in discussing this topic. So kind of laying some groundwork. What is hypogonadism? There's multiple different reviews or different criteria that can classify someone as hypogonadal. I went with the American Urologic Association, which states that to be hypogonadal and to have this diagnosis, there has to be a biochemical level of 300 or less than 300 total testosterone, as well as symptoms of hypogonadism. This chart here shows some of those common symptoms that somebody would experience with that, such as reduced energy, decreased libido, erectile dysfunction, so on. So, specifically, I wanted to talk on secondary hypogonadism. This is a problem that is experienced with decreased testosterone production at the level of the hypothalamus or the pituitary. Some common causes of this can be organic causes, such as prolactinomas, sarcoidosis, trauma, iron overload, or Kallmann syndrome. There are commonly, though, other causes of secondary hypogonadism, such as obesity, chronic stress, poor sleep, overtraining, and substance use. This is from the American Urologic Association, showing the kind of diagnostic algorithm that can lead you to diagnosing someone with hypogonadism. For the secondary hypogonadism, somebody would kind of follow along this pathway. Symptoms of hypogonadism, the low testosterone, less than 300. You would then obtain LH, FSH, other labs as well. If those were low, then prompting you to get prolactin levels, if that is normal, leading you to confirm diagnosis of testosterone deficiency, and then that can lead to treatment. So I decided to pick this topic specifically because since starting medical training, I've noticed a huge amount of people asking me or talking to me, being like, hey doc, what's going on with all these different supplements that I'm seeing on social media? Should I be tested for hypogonadism? Do I need treatment for hypogonadism? And so I feel like to be better taught in this, better, have some better information for them, I should do this study. So as of right now, the incidence of hypogonadism is increasing, or at least the workup and diagnosis of it is increasing. In a study completed in 2013, there was a 4-fold increase in males of reproductive age seeking testosterone replacement therapy. In the beginning of the study, there was 29 males per 100,000, which increased to 118 per 100,000 in 2013. This study was specific to reproductive age males, so from age 18 to 45. If you go off of, there are some more recent studies that include males of all age. This was concluded in 2017 that shows that there was about a 5-fold increase in males seeking and undergoing treatment for hypogonadism. So as of now, the mainstay treatment or the most common treatment for hypogonadism is testosterone replacement therapy. Unfortunately, one of the most common side effects associated with this is infertility. And so I do believe that that is a significant concern that many patients or friends that have talked to me about treatment for hypogonadism are unaware of or not monitoring closely. And so in some more recent studies, there's been studies on clomiphene citrate as an alternative treatment for this. Clomiphene citrate works by blocking estrogen receptors in the hypothalamus, which in turn, through the hypogonadal axis, increases gonadotropin receptor hormone, FSH, LH, FSH, and then total testosterone. It has been used for about 30 years. Although it is off-label, it still lacks FDA approval. This can work to increase endogenous testosterone production without the complication of infertility or some of the other common side effects. Currently, the most common treatment options include clomiphene citrate from 25 to 50 milligrams daily or every other day. Some of the common side effects that are associated are gynecomastia through the increase in estradiol, and then some visual changes or mood instability. Some different studies that I was able to find on clomiphene citrate as an alternative treatment for hypogonadism. This study completed in 2013 shows how effective clomiphene citrate is for this treatment. This uses one of the long-term studies, and so it's able to show how clomiphene citrate works over a longer period of time. In this study, there was 153 hypogonadal males through both biochemical and symptomatic diagnosis that were treated with clomiphene citrate. The diagnostic treatment included 25 milligrams every day, or 25 milligrams every other day, or 50 milligrams if the body mass was over 100 kilograms. They were able to find that there was significant increase in testosterone, total testosterone biochemical levels, as well as improvement in the hypogonadal symptoms. This study was beneficial because it goes out to the time period of 7 years. Unfortunately, there wasn't great follow-up, and so the numbers needed, or the participants in the study at the end were a lot less than at the beginning. In a meta-analysis, there was on clomiphene citrate, systemic review and meta-analysis, there was 19 studies that were included. It was 17 meta-analysis, showing great evidence on the effect of clomiphene citrate as a treatment option for hypogonadism. Again, these studies use both biochemical response as well as a symptom score sheet called the Adams Questionnaire for both diagnosis and then treatment response. One of the most interesting studies that was included in the meta-analysis was the study done by Dr. Suarez in 2018. This was one of the first double-blinded random controlled study that showed reproductive age males having a response both, again, biochemically and symptomatically to clomiphene citrate. The study that was included here, unfortunately, this is data that was pulled from the meta-analysis. This included, the units were in nanomoles per liter versus the other ones, which were nanograms per deciliter. So that's why it looks like it doesn't have any response. So One of the questions that arose to me during this study was, why is clomiphene citrate not used as often as testosterone therapy when it has such significant improvement, as well as does not carry the side effect profile as testosterone? Unfortunately, I was unable to find any specific head-to-head studies in reproductive age males that address this topic. But in a study that showed head-to-head studies for all males, it does show that clomiphene citrate is again effective. However, it does not raise the total testosterone levels to the level of testosterone replacement. In this study, it shows comparison of clomiphene citrate of total testosterone levels before and after in comparison to total testosterone levels in those receiving the injections. For the males receiving clomiphene citrate, again, it was 50 milligrams daily, and for total testosterone, for TRT injections, it was 100 or 200 milligrams every 2 weeks. This study does emphasize, though, that despite there being more total testosterone, or the levels rising more, the total testosterone levels rising more for TRT injections, the symptomatic score sheet was very similar between the two treatment groups. In conclusion, through multiple studies, I do believe that clomiphene citrate is a safe and effective way to improve secondary hypogonadism for reproductive age males. Specifically, I think it's important to address that there can be improvement in total testosterone as well as symptoms of hypogonadism without the concern for infertility. So, thank you.
Thank you, everyone, for that, and thank you to our speakers. We're going to do a little break before our second half to allow our first section speakers to come up here so they can answer some of your questions. If you want to ask a question, please go to one of the microphones. As they're coming up, I failed to mention that this section is being sponsored by Intermountain Health, but we also have special sponsors for this section that include Steve F. Johnson, MD, Joyce Johnson Stillwell, and Val B. Johnson, MD. And they're sponsoring this in memory of their father, Vernal H. Johnson, MD. So we're really appreciative of their sponsorship, and we're grateful for our first speakers. So if anyone has any questions for the first four speakers, go ahead and ask them now, and then we'll do this again after the second group. So let's see. You go ahead.
So appreciate all the research. Great job to each one of you. Those are important topics. I've seen each one of those in my own clinic as a family physician. To the last speaker, did you look at any N-clomiphene rather than clomiphene for supplementation? In my own reading of it, there tends to be fewer side effects with the N-clomiphene versus clomiphene.
In the ones that I studied, it was just clomiphene. It did not talk about N-clomiphene. But the ones that I specifically brought up in this research were specifically clomiphene, but I did see that N-clomiphene is also effective.
Okay, thank you.
My question's for Chase. So Chase, being one of the attendings that's repaired vaginal lacerations with you guys, have you guys ever considered just like letting the patients tear so you get some more experience with that? You know, just joking. No, but I do wonder though, like how if you guys were able to track like how many vaginal laceration repairs you had during that time, if that kind of impacted that at all, if like how many you guys are able to see and repair, because as much as repairing like a cow tongue is helpful, there's nothing that really compares to doing it in person with a real patient and everything.
Sure, no, that's a good question. I did track that. I and that's something that's tracked independently, right? Each resident is tracking that. But I did also ask that question of the residents. I didn't include it here, but typically in residents who then stated that they felt less comfortable than they were uncomfortable repairing it without close supervision, they often then cited a low number of repairs as their number one reason. And so some of those residents were reporting, numbers between like 0 and 3 lacerations repaired. And so I think that, makes good sense that they were uncomfortable repairing the lacerations.
So those residents are just doing a good job of protecting the perineum.
Exactly,
right?
protect the perineum, exactly.
Yeah,
So,
okay, good job, thanks.
Hi, my question's for the first presenter. Great job. I think that's exciting, and that you're able to provide gender-affirming care. And my question was about whether you are treating juveniles. I know that's a controversial area.
We are not,
Okay.
no. Yeah, it's controversial, and as far as I'm aware, Utah laws don't allow that right now either. So we're trying to stay in compliance with Utah laws, and it also is much more complicated to treat juveniles as well too. I think well beyond our training right now, and we're in the beginning of it all. So even if it were within Utah laws, it would definitely be something that we might still be referring down to Salt Lake. Thank you.
Thank you.
My question's for the last speaker on the Clomid. So recently there's been some studies where testosterone therapy actually helps protect against cardiovascular disease. Did you read anything, or can you speak to Clomid? Does that also help protect like testosterone therapy does?
I did not see anything on that, so.
I'd like to address the first speaker for just a minute if I can. So I've noticed this trend when people do something that might be a little bit morally controversial. And the trend is to make blanket statements about why something needs to be done. In this case, a blanket statement about suicides. And although I do appreciate that, it also leaves out the other side of the equation. So my question is simple.
Okay.
What harms are there in gender-affirming care?
I think that is a fair question. Thank you. I think the harms within gender-affirming care lie within the harms of estrogens and testosterone therapies in general. There's a lot that still needs to be heavily studied. I think we are very wary of the fact that we are very new in the process of doing this in our clinic. There's a lot that still needs to be studied. And so we are very careful in our clinic to try to mitigate those harms by screening past medical history with the patients right now. And if something were to arise with increasing risk factors with these treatments with their pertinent past medical history, that's when we would be making phone calls to Salt Lake. Doctors Chaudhary with Intermountain and Dr. Sullivan have both reached out to provide their assistance to us with this, but also that's the caveat: if harms are high enough or the risk is high enough that would make us nervous, we'd be sending them to Salt Lake. Fortunately, that has not come up with our clinic patients.
Question for Dallin. So you talked about the variability of PRP injections as far as kind of the injection itself and how you prep the product and how you give it and so forth. I guess the other variability is what happens afterwards. What's the protocol for activity, and do you do physical therapy? Are you immobilized? Do you take NSAIDs or not? I mean, there's a lot of variability there as well. Can you speak to that?
Yeah, so the earlier studies, there wasn't as much restriction around NSAIDs, which also makes the earlier studies not as accurate, I'd say. More of the more recent studies all have at least a couple weeks of no NSAIDs before the procedure, and then at least several days of no NSAIDs after to be included. There wasn't any of the meta-analysis that really talked about follow-up physical therapy or how many injections were done, because some of those studies there was a shot follow-up, whether it was a month apart or 2 months apart, and so they didn't categorize it. They just lumped it in as this study was beneficial, this study was not, and that's really part of the challenge. And so The protocol we'll use for like NeoA is usually MSite. It's one of the most common ones, and has great data behind it, but insurance are lagging. I feel if insurance jumped on it, NeoA would be not first line, but right up there with everything else.
We want to thank our first group of speakers. We'll give them one more round of applause. They've been working very hard on these projects, and I really appreciate the hard work on top of a busy resident schedule. All right, and so we are now going to go into our second section. We have 3 speakers, which will present just like the previous section. We'll first be hearing from Dr. Hatch, followed by Dr. Gillis, and our final speaker will be Dr. Edwards. Afterwards, we'll have some time for questions for those 3. Thank you.
Hi, everyone. My name is Akusia Hatch. I am one of the third-year residents, and my project is on improving vaccine access at Seeger Clinic. It's a clinic that's very dear to my heart. I've been involved with them since medical school, so I was very fortunate to be able to continue working with them in residency. I do not have any disclosures. So for those of you who are not familiar with Seeger Clinic, it's a nonprofit free clinic that provides dental, medical, vision to a lot of the vulnerable populations here in Ogden. And since 2021, it's been having this annual health screening day, usually a day in the fall. It offers a wide variety of health screening services. So patients are able to, get their general medical screening alongside dental screening for women, pap smear, vision testing, etc. And this is a brochure from last year's. So as I mentioned, it started in 2021. That was like the pilot program. And then 2022, we noticed like an increase in Spanish-speaking attendees. And then 2023, we added a community resource table. And in 2024, we moved to OTEC to hold the clinic. And therefore, my mission was to improve immunization to prevent diseases in vulnerable populations in Ogden. So why immunizations? First of all, is to provide protection for our vulnerable population. Here are the demographics of patients who frequent Seeger Clinic. 60% are uninsured, majority are local, and over 1/3 report being homeless, and 65% report being below the federal poverty line. Other reasons being herd immunity, so that's the protection of those who cannot be vaccinated when the large population are vaccinated. Reducing healthcare costs, so as we know, immunizations help prevent diseases, and therefore we are saving money on treatments, on hospitalizations, absence from work, etc. And then also just improve public health in general by reducing disease burden and disability. So last year, we applied for a community health fund with Intermountain, got awarded about $20,000, and we decided to hold an immunization clinic in the spring of 2024. We were able to reach out to some of our major collaborators like Weber Morgan Health Department, OTEC, and during the discussions, OTEC offered to provide dental cleaning, but preferably at their facility. It's larger, they don't have to move their equipment to where Seeger is currently located. That's the Ogden Rescue Mission. So we were able to provide some immunizations. Unfortunately, it was very limited. We anticipated it was going to be a small event, so we didn't think a lot of people would show up. So we actually ran out of immunizations. But because of just being there and the experiences, I don't know if you guys have ever attended the annual health screening at Seeger, located in the rescue mission. It's a very small space, very tight, tons of services being provided, and that makes it just a little bit complicated getting people around. So it wasn't kind of like a brainer to just decide to see if OTEC will be willing to hold the annual health screening day at their facility, which they were very gracious enough to let us do that. So since there was the plan to hold at a bigger facility, we're hoping that with a bigger location, we'll have more people and therefore more immunizations. And therefore, the aim was to increase access to vaccines by 15% at the 2024 annual health screening day compared to the previous years. And just a heads up, we weren't able to collect data from the 2021 study. So the results are going to be from 2022 onwards. So as you can see, we almost doubled the amount of vaccines administered at a bigger location. I think just being at a bigger location, parking spots, again, OTEC has just a lot of space for that, and we have a lot of community collaborators who were able to help advertise the event to help with that. And this slide shows just the various vaccines that were administered and just how many of them. We saw an increase in Tdap, Hep A and B, Shingrix administered more, and last year we were able to add MMR to it. And just a couple of pictures just showing some of our volunteers helping out, and we had over 100 people showing up that day last year. I would like you to pay attention to this slide. I was just interested in seeing the demographics of people that attended the 2024 annual health screening day. As you can see, majority of people are adults and majority are uninsured, unfortunately. So what does this mean? This makes me think of non-medical factors that affect one's health care. As you can see from previous slides, we have patients who are uninsured, living below poverty lines, report being homeless. And when you add lack of access to health care in the mix, it's a very dire situation. And that's where Seeger Clinic comes in. And I would like, if not for anything, I'd like you guys to just be aware of this local entity that is trying to accommodate our vulnerable population in that regard. And to just kind of stress the importance of having a clinic in our community and making sure that you're aware and can help support it as much as you can. So next steps for Seeger, fortunately, Seeger's been able to acquire a clinic on 24th Street. There's just a lot of remodeling going on right now. So hopefully by the end of this year, it will be able to relocate to a bigger, more permanent facility. And that's something that I would like you to be aware of. And next steps for me, I will be joining Intermountain post-residence. And I would like to acknowledge specifically Jerica and April with Seeger Clinic, our partners with Weber Morgan Health Department, OTEC, Intermountain Health, my attendants, and our other community collaborators that we work with usually. And thank you for your time.
Hello, my name's Taylor Gillis. Today I'm going to talk about menopause and hormone replacement therapy. This is again, I guess we're on a theme of controversial topics here this year. And this is definitely one that over the years has had a lot of controversy, so I wanted to understand it better for treating my patients in primary care. Next year I'll be heading down to Durango, Colorado, and an FQHC down there called Access Health System. I got no disclosures. Hopefully by the end of the talk, I'll meet my 4 objectives, which are to define menopause and its clinical features, review the history and the controversy of hormone replacement therapy, analyze 3 major studies regarding hormone replacement therapy, its risks and benefits, and then identify the optimal patients for hormone replacement therapy in postmenopausal women. So menopause, 12 months of amenorrhea in the absence of contraceptives. This average age is 49 through 52, and this can be achieved through surgical management, also chemotherapy, other more obscure ways. For the purpose of this presentation, hormone replacement therapy will be defined as estrogen only in women without a uterus and estrogen plus progesterone in women with a uterus. Clinical features of menopause, vasomotor symptoms, sweating, hot flashes, impaired sleep, mood swings, depressed mood, vulvovaginal atrophy symptoms, urinary atrophy symptoms, weight gain. So a lot of you know this better than I do, but over the years, there's been a big swing in how hormone replacement therapy has been prescribed in the United States. Back in 1940s, Premarin was produced. This is an estrogen-only product. It was approved for vasomotor hot flashes, prescribed widely until the 1970s when there was found to be elevated risk of endometrial cancer, and therefore progesterone was added in order to supply the endometrial protection. 1980s and 90s, there was multiple observational studies that showed benefits for all-cause mortality, cardiovascular, breast cancer, as well as dementia. However, all this positive progress came to a screeching halt in the 2000s with the release of the WHI, or the Women's Health Initiative, which kind of turned the whole hormone replacement therapy world upside down. This reached popular media, and there was a lot of crisis in both the patient population and providers. And you can see here, after the release of the WHR, there was a sharp decline in hormone replacement therapy prescriptions. So I'd like to take a closer look at the WHI and kind of understand the data and why there was such a panic regarding the results. This was a very large study, the largest randomized controlled study to date. We looked at 27,000 different women. They were randomized to either receiving estrogen only if they had no uterus, or estrogen plus progesterone if they still had a uterus. They enrolled them in age 50 to 79 in the early 90s. The primary endpoints of the study were looking at coronary heart disease. They had multiple secondary endpoints, but one of the primary adverse outcomes they were looking at was breast cancer. One of the criticisms of the WHI and how it relates to our patient population today is the baseline characteristics of the patients. Women in the study, on average, were almost 60% were over the age of 60. 2/3 were either overweight or obese. About 50% were either past or current smokers. 1/3 were being treated for hypertension, and 20% were using aspirin for some indication. One of the wings, the estrogen plus progesterone wing, was actually stopped early in 2002 when the Data and Safety Adverse Monitoring Committee noticed both an increase in invasive breast cancer as well as cardiovascular, negative effects on cardiovascular outcomes. You can see here the relative risk of 1.26 with that confidence interval there for invasive breast cancer. And there was increased risk in cardiovascular disease, stroke, and venous thromboembolism. There were a couple of positive findings from this wing, including a decrease in the incidence of colorectal cancer, as well as decrease in osteoporotic fractures. I wanted to take a closer look at that invasive breast cancer, which was one of the causes for the study being stopped early. So the relative risk of 1.26, if changed into absolute risk terms, this is about 0.08%, or 8 in 10,000 person years. You can see here on the graph on the right, as the incidence of the invasive breast cancer increases at 4 to 5 years in the hormone replacement group here, it's actually also accompanied by a decrease in the incidence of invasive breast cancer in the control group, which can kind of falsely elevate that relative risk. If we're looking at other relative risk factors that are associated with breast cancer, alcohol use is also the same at 1.26. Digoxin use is greater at 1.39. Calcium channel blockers, being left-handed, being a flight attendant. For other cancers out there, tobacco smoke has a relative risk of 26. The other reason that the study was stopped early was for coronary heart disease. This was initially a non-significant finding of 1.24 as it crosses that confidence interval of 1. Later reworkings of this data, as they finalized it the following year, found that actually the only significant incidence of coronary vascular disease in the first year, and later on there was no longer an increased risk. So the take-home points from the estrogen and progesterone wing from the WHI, the study group was relatively old, and they had higher cardiovascular risk factors. Increased absolute risk of breast cancer was 0.08%. There was an overall non-significant risk of coronary heart disease, except for in the first year, twofold increase of venous thromboembolism and a decrease in osteoporotic fractures. The other wing of the WHI was the estrogen-only wing in women that did not have a uterus. This was also stopped early, as they found to have an increased risk of stroke. There was also increased risk of venous thromboembolism. There's no effect on coronary heart disease. We again see that decreased fracture from osteoporotic disease. And interestingly here, we're seeing a decrease in invasive breast cancer. Here, we're seeing that this does include the confidence interval of 1. However, again, on later reworkings, as more additional data was developed from this did become significant decreased risk. So again, in summary, increased risk of stroke in estrogen only, increased DVT risk, decreased risk of hip fractures. There's probably a decreased risk of invasive breast cancer in estrogen only, and no effect on cardiovascular disease. The next study that I'd like to take a closer look at was released in 2012. It looked at a data set from the 1990 Danish osteoporosis prevention study. This was titled The Effect of Hormone Replacement Therapy on Cardiovascular Events in Recently Postmenopausal Women. This looked at about 1,000 women, again randomized then to either receiving hormone replacement therapy or control, and it depended on if they had a uterus or no uterus. The primary endpoints of this study were a composite score of death, admission to hospital for MI or heart failure. Secondary endpoints were the individual components of those, and they had multiple safety endpoints as well. Overall, the patient population of the study were younger. They had a BMI of 25. Their LDL in United States terms, that's about a 140 something, 140, 150. Systolic blood pressure was 130. I'm not sure if that was treated or not. And this was the 90s, so nearly half were smokers. If you look here, you can see that the overall finding of the study for the primary endpoint showed a decrease in the primary endpoint of mortality, heart failure, and myocardial infarction. This did not remain true for women over the age of 50, but for women less than 50 years old, this was true. And then again here, a trend towards significant decrease in women that had a hysterectomy, meaning that they're on estrogen only. The majority of the other findings here were not significant, so there was no increased risk of DVT, stroke, breast cancer. There was a composite score here, mortality of breast cancer, that showed a decrease, and again in 50. So the take home from this is initiation of hormone replacement therapy in women in early menopause significantly reduces the risk combined endpoint of mortality, myocardial infarction, and heart failure. And early initiation of hormone replacement therapy did not increase the risk of breast cancer or stroke. The last study that I'd like to take a look at is a Cochrane meta-analysis or systemic review. It looked at 19 different RCTs and about 40,000 different women and the effect of HRT on cardiovascular risk. The first part of this is primary prevention of cardiovascular disease in postmenopausal women. There was no effect on all-cause mortality. There was no effect on cardiovascular death. There was an increased risk of stroke and this persistent increased risk of venous thromboembolism. This is both in estrogen or estrogen plus progesterone. They didn't separate out. Second, they looked at secondary prevention of cardiovascular disease in women that have established cardiovascular disease. There was no increase of risk of death. There was no increase risk of cardiovascular death. There was no increase with stroke. But again, we see this persistent doubling of venous thromboembolism. And for the last group that they looked at, this was hormone replacement therapy commenced less than 10 years after the menopause for preventing cardiovascular disease. In these women, there was a decreased risk of all-cause mortality, decrease of cardiovascular disease, no effect on stroke, and again, this increased risk of venous thromboembolism. So this kind of introduces this timing hypothesis, which we know today. In women that are greater than 10 years since menopause and greater than 60 years of old, we see no effect on all-cause mortality or coronary heart disease, but probably a trend towards harm. But in women that are less than 10 years since menopause and less than 60 years old, we're seeing a decrease in all-cause mortality and a decrease in coronary heart disease. This is not placed here for you to memorize all the different benefits and risks, but just to show that this is kind of a muddied picture. There's a lot of different things that can go right and a lot of things that can go wrong in estrogen therapy, estrogen plus progesterone therapy. So thankfully, societies have come out and made recommendations on an individualized risk assessment for women considering HRT. These women that are at really good candidates for this are women that are aged 50 to 59 with recent menopause, and they have to have bothersome vasomotor symptoms. All the studies that I referenced here, at least the first two randomized control studies used oral hormone replacement therapy. The Cochrane meta-analysis uses various different types, but we do know now that patches decrease your risk of venous thromboembolism, and then you can use other endometrial protection like IUDs. For our lowest risk individuals, these are women that have recent menopause, normal weight, normal blood pressure, and they're very active and they have a low ASCVD risk. These women, the risks or the benefits probably outweigh the risk in treating their vasomotor symptoms with HRT. In this middle group, women that are diabetics, that are smoking, that have uncontrolled hypertension, autoimmune disease, obesity, and they have that kind of moderate ASCVD risk, you really need to have that risk-benefit discussion and seeing if HRT is right for them. And in the higher risk group, women that have ASCVD that's known, previous VTEs or PEs, strokes, clotting disorders, known breast cancer, or really high ASCVD risk, these are women that are probably not good candidates for HRT. So I like this slide because it kind of just helps wrap up the society recommendations today. That is all I have for you. Thanks for your time.
I'm a lot shorter than my colleagues. My name is Rebecca Edwards. I'm one of the third-year residents at McCady Family Medicine Residency, and I chose to do a literature review this year on asking the question, what is the effect of weight loss on infertility? Okay. First off, I have no conflicts of interest giving this lecture. Just to get out of the way, just some terminology that I'm sure we're all very well aware of. Infertility is the absence of conception within 1 year of unprotected sexual intercourse. Fertility is the capability of producing an offspring, and fecundability is the ability to achieve a pregnancy within a menstrual cycle. So some common causes of infertility that we are all probably very well aware of, endometriosis, ovulatory disorders, poor sperm quality. There's also unexplained, and then many more. There's also lifestyle and just the age at which patients decide to start a family. Some interesting statistics that I came across while doing my research. According to the World Health Organization, 20 to 30% of couples worldwide are infertile. And the peak age of fecundability for men is before age 35, and for women before age 30. So when coming up with my research project, I asked this PICO question. for my population. I wanted to look at obese women with infertility. And for the intervention, I wanted to look at weight loss through diet and lifestyle modifications. And then I wanted to compare this with the same population of patients that had no intervention, and then see what the effect was on infertility. Why do we care? We have a lot of patients coming into our office and with obesity, and obesity has big impacts on fertility. Obese patients are more likely to have ovulatory dysfunctions. They're also more likely to have poor outcomes when it comes to reproductive assistance with trying to conceive. And they also have higher risk of impaired implantation and also increased risk of miscarriage. And there's also risk factors with pregnancy when it comes to obesity. They are more likely to have complications during their pregnancy, such as gestational diabetes, gestational hypertension, preeclampsia, and other and then they're also at an increased risk for postpartum complications or delivery complications, such as emergency C-sections or instrumental deliveries and hemorrhage. The first study that I looked at, the Fit Please randomized control trial, was published in 2022 in the PLOS Medicine Journal. And they looked at 379 women with obesity aged 18 to 40. And these patients were obese with unexplained infertility, and they were separated into two different groups, a weight loss group and a standard group. And they did have some inclusion criteria in this study. They had to be of good health. They specifically looked at unexplained infertility, so they had to have normal ovulation, they had to have normal anatomy, there couldn't be any fallopian disease involved, and they had to have a fertile male partner. For the first group, or the intensive group, the first group, they had a weight loss goal of 7%, and this was done through diet modification. They had a pretty strict caloric diet that they had to stick to. They were also put on a gastric lipase inhibitor, orlistat, to decrease absorption of fat. And then they had modifications in their inactivity with a goal of working up towards 10,000 steps per day. And this was all done over a 16-week period. And then the other group, the standard group, their goal was to maintain weight. And the only intervention they had was just increasing their activity with the same goal of working up towards a 10,000 steps per day activity. Again, 16 weeks was done for this as well. And this was all in the first phase of the trial. The second phase of the trial, then anyone who did not get pregnant naturally, they were able to receive up to 3 cycles of infertility treatments. And during the infertility phase, or during the treatment phase, then both groups were advised to maintain their weight and activity level. The primary outcome that they looked at for this study was a healthy live birth, which was defined as a term newborn born between the 2.5 and 4 kilograms without any major congenital anomalies. They also had secondary outcomes that they looked at as well. And if you see here, you can see that the number of patients that conceived in each group was very similar. But when you compare the pregnancy losses with the intensive group versus the standard group, there were more losses in pregnancy with the intensive group, 24 versus 14. Here's some more additional data. The primary outcome was the healthy live birth, and the number was lower in the intensive group compared to the standard group. In both the healthy live birth, the primary outcome, and then also total live births in general. This here is the same data that we looked at, but just in chart form, so you can kind of compare the percentages of the different groups. And if you see one that kind of stands out the most is the pregnancy losses were higher in the intensive group compared to the standard group with weight loss versus maintaining weight. But if you compare the p-values, there was no real statistical significant difference between the two groups. So this study concluded that in patients with obesity and unexplained infertility, then a weight loss goal of 7% did not increase the rate of a live birth or in any live birth. And 59% of the patients in this study were able to meet that weight loss goal of 5% or more with an average of 6.6%. So they did pretty good in the intensive group meeting that goal. Some limitations of the study: the weight loss was the gold standard for weight loss treatment, but it may or may not be gold standard for infertility patients and patients trying to conceive. And then this study didn't really look at the long-term goals or the long-term effects of the interventions. So, and they didn't really follow patients much past the conception and birth. But they were able to isolate the best that they could obesity as being potentially a cause for the infertility, because they had to have all other unexplained or explained infertility causes ruled out. Another study I looked at was published in the New England Journal of Medicine in 2016. They looked at 577 women and separated them into two different groups, the intervention group and the control group. They had some inclusion criteria in this study as well, but they were less strict. They could have unexplained infertility, they could have PCOS or anovulatory disorders or fallopian tubal dysfunctions, but they too did have some exclusion criteria. For the intervention group, they focused a lot on diet and lifestyle and counseling. Patients were put in contact with a dietitian and a counselor. They had to have a minimum caloric intake, and then also had to increase their activity as well, was the 10,000 steps a day, and then 2 to 3 moments, 30-minute exercises that they did every week. And this was all done over a 6-month period, so a longer period of time. And then comparing to the control group, where they went straight into infertility treatments. And I forgot to mention, for the intervention group, they did this for 6 months, and then it was followed up with 18 months of infertility treatments. Versus the control group, they went straight into infertility treatments, and depending upon their reason for infertility, they either went into cycle tracking and education versus clomiphene or other interventions to conceive, for a total of 24 months. They had their primary outcome was they looked at was the vaginal birth of a healthy term newborn without any complications, and then they also had the secondary outcomes that they looked at. And I guess I'm sorry that this box is a little misplaced, but you can see here that for the vaginal birth, their primary outcome was in the intervention group was actually less compared to the control group. And then the total live births was also less, 123 versus 153 in the intervention group versus the control group. And then these are just other things that they looked at, the secondary outcomes, in comparing both the groups. Another thing that I thought that was pretty interesting that they looked at was the methods for conception. In the intervention group, the patients that worked on weight loss, they actually had a higher incidence of natural conception when compared to the control group when they went straight into infertility treatments. And then the number of infertility treatments was less in the intervention group compared to the control group. In conclusion, with this study, then weight loss prior to infertility treatments did not improve the rates of pregnancy, live births for these patients. It did decrease the number of patients requiring infertility treatments, and it did decrease the number of treatment cycles needed to conceive, but it overall didn't make any difference in the number of live births seen. So some limitations: only 38% of the patients met their weight loss goal, and there was some potential concern of adherence to in the intervention group. And this study didn't really isolate obesity. There was other things seen, and maybe weight loss has a higher impact depending upon the reason the patient might have some infertility. Overall, in comparing these two studies, weight loss, again, didn't improve the primary outcome of a pregnancy or in live births. But one thing that I didn't discuss due to time constraints was the effects, other ways that patients lose weight. There's bariatric surgery. I did run into some studies that showed that weight loss through bariatric surgery can improve rates of infertility in patients who have anovulatory disorders. And then new upcoming research is being done currently on the effects of GLP-1 receptor agonists and the weight loss and how it affects infertility. These are my resources.
All right, that's the conclusion of our second group of speakers. We're going to ask them to join us up here on the stage. If you have any questions for them, and I encourage you to ask them some questions about these projects, please step up to our stand so we can ask them. While you're doing that, people oftentimes ask me how these projects are decided on by the residents, and I want to just kind of give a little insight into how this is done. All the residents we're hearing today have picked these topics, and they're things that are passionate to them. You can see there's a lot of variety in what types of projects are undertaken, and that's really meant to help them as they're starting to develop how their professional identity is going to be out in their future practice, and so they're developing those skills to do critical analysis and perform projects that they'll hopefully be able to continue in their future practices. And so I do appreciate the hard work that they put in. Let's go ahead and start with the questions up here.
So thank you, great job again to each one of you. To the last presenter, was there any measurement of rebound weight gain for the intervention group in either of the studies?
Yeah, and I kind of mentioned that in the limitations of my first study, is they didn't really look at the long-term effects on these patients that they did the intervention on. So that's something that would be interesting to see and consider as far as the long-term effects. They didn't mention that, no, not in the
So
first.
even during the pregnancy, it didn't show that though they improved infertility, they gained excessive weight during the pregnancy, which then negated the benefits. It didn't look at that.
No, they didn't talk. I mean, they did look at the weight gain during pregnancy, but as far as comparing the intensive group versus the control group or the other group, there was no statistical significance between the two. Is kind of what they were mostly looking at. Would weight loss prior to conception affect any of that? No. They, interestingly enough, in the first group, they did talk a lot about and look at like other cardiovascular risks, and those risks did go down, but as far as fertility itself, didn't make a difference.
Thank you.
Mm-hmm.
Hey, congrats to everybody. Great presentations this year. I didn't want the time to go away without Dr. Gillis being put on the spot, so I got to ask him a question. Dr. Gillis. So there was a point in your presentation where I'm not sure if I was dozing off or if you were trailing off. I didn't quite hear what you said, but it had to do with utilization of IUD in hormone replacement therapy, and I almost couldn't even think about Dr. Edwards because my brain is just going on that right now. So would you talk about that a little bit? I mean, in my practice, I have patients, I've been in the same practice for a long time, and they're the women in my practice are in this age group. And a lot of them in my practice have the levonorgestrel implant, IUD, Mirena or Liletta. And it's always a dilemma, when do I take it out? When have they lost the capability of fertility? But now you got me thinking, and I want you to talk about this just for a second, if you could. Why not just leave it in for the full 8 years? For the full 8 years, and give that endometrial protection if I'm going to treat with hormone replacement therapy. Thank you.
Yeah, so the progesterone in the IUD is purely for endometrial protection. I think a lot of studies would suggest that the progesterone might be actually the more dangerous of the two, and so that's why using like a patch rather than the oral estrogen to reduce the venous thromboembolism risk is helpful. And then the IUD is purely there for endometrial protection, not adding to any of the systemic HRT. But there's other ways you can do it in women that prefer not to have an IUD. I don't know about Nexplanon on its indications for endometrial protection for that, but there are oral formulations for progesterone that you can use as well. Did that answer your question? He had said that the orals, progesterones, are typically not tolerated well, so he had not thought about using the IUDs. And that good? Yeah, I think I heard that. Yeah.
So I have a question for the same speaker. So this is kind of a controversial question, but we don't need to get into it. But in the studies that I read, the HERS study and the WHI, they use synthetic hormones, and so estrogen, progestin, which is also what's in the IUD, but there's studies out there with bioidentical hormones, progesterone and estradiol, so they're different, it's just those words are used interchangeably. And the bioidentical hormones have the same benefit of protection against female cancers, cardiovascular disease, but I don't believe in the studies there's the risk for the thromboembolism. And so I think that that's, like I said, it's controversial, but those are some studies that I read, I just wanted to add.
Thank you. Yeah. I didn't do a very good job at explicitly stating those.
Question for Akos. So I guess the vaccination in a one-time setting at a health fair, I guess one of the challenges I've had, because I've been at that fair, is batching all the vaccines all at once. You know, we do it for kids and don't really blink an eye, but for adults, we tend to be a little more skitterish about giving a lot of vaccines all at once. So any comment on that, about in the adult population giving vaccines on a one-day event versus splitting them up?
Thank you. That is a very good question. I don't think we've actually looked into that at Seeger to see. A lot of times we obviously will ask certain questions regarding allergies, if they're sick or whatnot, but in terms of multiple vaccines at once, I don't think. But that would be something interesting to look into to see. Thank you for bringing that up.
I also have a question for you about the vaccinations. Certain vaccines are one-off kinds of vaccines, but a number of them require a series. And I don't know if this population that you have at this clinic are people who've had these series as children and youth and are just coming in for boosters or whatever. But if they need a series, how do you handle follow-up and have them come back for the next in the series and the next in the series?
So during the regular clinic days at Seeger, we have a vaccine voucher program that we give to patients that they can follow up at the Weber Morgan Health Department for that. That's like the best we can do for right now. There are obviously different barriers, geographic, transportation, economic barriers to that, but so far that's the system we have in place for patients to kind of have follow-up vaccines, especially when they're in series.
One more question for the Seeger Clinic. Vaccine hesitancy that I've seen has been greatest with COVID-19 and with the MMR. Did you see changes in those two particularly? Is one of the questions. The other question is, what age ranges were you giving the COVID-19 vaccines to?
Okay, so majority of it, patient population, especially on that day, were adult population. And this is, I don't have any data back in this, but in my experience, I feel like we don't have a lot of hesitancy regarding vaccines. I feel like people are just more than happy and make sure they want to get immunized for, you know, just their life and healthcare in general. Yeah, so it's just hard, just from my experience, and we try to kind of encourage our providers to talk to patients regarding vaccines, and we do talk to them, but I don't know if you recall, like Maslow's hierarchy is, a lot of people are just dealing with just lack of basic necessities, so we try to incorporate that in the visits, but a lot of them are just coming in for either like their diabetes or certain acute care things, and we try to kind of sneak in the vaccine lecture, and we provide the vouchers, and we just hope that they're able to utilize them like during the regular clinics. But we kind of see more of almost like a one-stop shop with the annual health screening day. We see so many people come in, and it's like that's the best time that they know for 4 hours they can get a ton of things done. So that's another avenue that we have as well.
Well, I have a question also for Dr. Gillis. The one scenario I run into occasionally are those women who, for one reason or another, had a surgical hysterectomy or were put into surgical menopause at a young age, who may be, so they may still be very young and healthy, but they are more than 10 years out from their menopause. Do you have any insight in kind of how I should be counseling those women?
And they're not currently on anything?
Well, they supposedly, I guess maybe, they've been on it for a long time. They want to know how long they need to continue it.
Some would recommend, I mean, that's a pretty special population. Overall, some would recommend decreasing it at the soonest possible point. So, or in that specific population, she was like at 30, you would do it when typical women go through menopause. But there's probably more recent recommendations that say if there's not negative outcomes that are occurring, you can continue it. But at the first occurrence of a venous thromboembolism or stroke or something like that, obviously breast cancer, that's probably when you would want to stop that.
Any final questions? Let's give a final round of applause for our speakers for today. We're going to end a little bit early here, but I do want to recognize that out in the audience, from what my view, I've seen several past speakers at this session. I want to thank you all for coming back to watch your classmates come and give their speeches. Just as a final announcements that I was asked to give, tonight again is the Ogden Regional Medical Society Pickleball Tournament. It's starting at 6 o'clock, going till 9 o'clock at the Pickler. The other option is dinner here in the Shepherd Union Ballroom, honoring Dr. Tainter, and we're going to have Ryan Shoup and the Rubber Band solo performance as the entertainment, starting at 6:30 p.m. If you're interested in either of those, talk out front. If you don't already have tickets or haven't already set it up, I think they might be able to help get you in. Tomorrow night, Friday, is the Holy Cross Hospital Davis and Tanner Clinic Family Night at Sequest in the Layton the Layton Mall, anytime between 6:30 p.m. and 9 p.m. And you can still register again for that up in the front. Otherwise, that concludes our regular activities for today, and I want to thank everyone for coming, and we'll see you tomorrow morning.